Okay, for our final presentation, Dr. Malcolm Ng is going to discuss perforations and infections after strabismus.
Thank you, and good afternoon, ladies and gentlemen. So I'm the caboose of this train of knowledge that has come along this way. I appreciate your hanging in to the last. And I want to thank the program committee for putting me on this position of discussing perforation infections. Just as an aside, the greatest fear that I knew of for Marshall Parks when I trained with him for a year was the fear of endophthalmitis following strabismus surgery. Apparently, he had seen a very serious case in which the eye was lost or the vision was lost. And just for starters, I'd like to, I know it's rare, but how many here either have a firsthand knowledge of either being a consultant or knowledge of a endophthalmitis following strabismus surgery? Could you raise your hand? Okay, so there's a fair number here that actually have experienced this situation, and I would like to get into this a little further now. No financial. Let me just go into the perforations first. Perforations may occur of the retina, but penetrations of the sclera may also occur without perforations of the retina. And let me explain that further. Your penetration will be actually a break that you will be able to see with the indirect ophthalmoscope. You'll see a little white spot in the sclera shining through the break in the choroid, but there will be no hemorrhage or retinal break. And we have really a low incidence of recognized scleral penetrations. John Simon some years ago found that only 1 in 1,000 were ever picked up after his prospective study. He said that these were not recognized. And furthermore, our late Gerhard Siebes found that there were only 2% ocular penetrations or scleral penetrations in his series, so it's pretty rare. Noel found 1.4% of penetrations with an additional 0.4% of perforations. But a series from UCLA, a prospective series of Dang et al. In 2004 showed that there were 5% penetrations and 3% of perforations. That totals up to 8%. So we can say that after 1990, approximately 1.4 to 8%, at least 8%, will have penetration of some type into the sclera. And why should we be really afraid of this? Well, first of all, we did try to get around the problem by designing the scleral spatula needle. I'm sure everyone here uses that type of needle for their strabismus surgery. But this was exactly the same type of needle that was used in the Dang study. So that shows it's not entirely preventive. And we do know something about when these penetrations occur. They seem to occur mostly in recession of recti muscles, and especially in highly myopic eyes, and has led to several surgeons recommending that you use a hang-back suture when you have a sea of blue choroid looking at you when you're recessing the medial rectus or the lateral. And the theory is that, and actuality is that the insertion site is thicker. So if you use a hang-back technique through the insertion site, you're probably less likely to penetrate the globe. Now, in the review of all the endophthalmitis that I could find in the literature, there were 22. Only four out of that 22 ever even knew they had a penetration during the case. And why should we be concerned about penetration? Well, it turns out from our colleagues down in New Orleans that needles are contaminated in 15 to 19%, so up to 19%. Sutures are culture positive almost to 30%. And these are the needles that you're using to insert the muscle into the globe. We know that there are methods to reduce bacterial count on these sutures, however. And I think the best suggestion I've heard lately is that you use the topical betadine or providine iodine before you put the speculum, and according to our retinal specialists, after you put the speculum in. Now, this is the additional one, and they have a prospective study showing that they reduce the count even lower by putting the providine iodine after the insertion of the speculum. So I routinely do this. I also routinely now soak my sutures because I know that if I soak it in povidone iodine, I can reduce the contamination rate down to about 9%. I can't get it completely sterile, but I can reduce the count. So there's a low incidence. And in 1991, I surveyed 63 Costa alumni members, including Marshall Parks, as what was the incidence of various types of infection. We found that endophthalmitis, which is the most severe, of course, and I think there's not a person in this room that would disagree with me that an endophthalmitis on elective strabismus procedure is probably the worst disaster that you're going to have to encounter, except maybe an anesthetic death, of course. But this is really disturbing. The signs and symptoms. There's malaise, there's fever, there's eye pain, there's a loss of appetite. I think in children, one of the first questions I ask the parents nowadays when I contact them by phone, or they contact me by phone, because I routinely, when I operate on children outside of the island of Oahu, where I do most of my surgery, if they're a neighbor island, I discuss this with them. I said, is that child eating? That's the first question I ask when they contact. There's asymmetrical lid swelling, and of course, in late stages, there's a hypopion, and there's cloudy vitreous and decreased vision. Now, this was an interesting statistic that came out of my study of the 22 cases. Symptoms started day 1 through 8 with a mean day of 3. So by the third day, the cases that were reported had symptoms. But here's the problem. The diagnosis was delayed until mean day 6, and it ranged from 1 to 14. So this really brings up an important point, because what if you just do a post-op day check, post-op day 1, and then that patient goes out of town? Never do that. Well, the thing to do there is to make sure, number one, the parents have the list of what you want them to be aware of, and you maintain contact with them. And there's no excuse in these days, with everybody having an iPhone, that you can, if there's any question, they can take a picture of that child's postoperative course and send it to you. Now, the treatment is intravitreal injections. However, prognosis is very poor. Only 8 out of the 22 cases retain useful vision, and this was despite vigorous intervention surgically for the endophthalmitis. Let's talk about something else. This is orbital cellulitis. Now, this is more common, and this is a bilateral case. I have to thank Sharon Friedman for the use of this slide. Orbital cellulitis is also a severe postoperative infection following strabismus. Kevin and et al., I think Ed Wilson was in on that study, analyzed 25 cases because they realized it's pretty rare. In my series, there was about 1 in 1,000 to 1 to 1,900 compared to 1 in 30,000 with the endophthalmitis. But all of these patients required hospitalization and systemic antibiotics. And there was a suggestion in their paper that patients under 5 should also have an examination of cerebrospinal fluid. But the prognosis is really much better. And in fact, none of these patients, the 25 in the series, lost vision with the orbital cellulitis, and actually 75% actually achieved the alignment goal. Another type of infection I reviewed, and it is not as common, and there were only 6 reported cases, but there's subtenon abscess. And these cases are somewhat different in the fact that there's a localized swelling over the muscle, and it's not the same as a generalized swelling of the orbit itself and the lid. But in order to clear it, if you give systemic antibiotics, it's still not going to clear unless you drain the abscess, but it does have a very good prognosis. And let's talk about the one that's probably the least destructive or harmful, but maybe more common. Conjunctivitis following strabismus surgery. It was interesting in the series that I did with the Cosmeter series that we also asked the participants to declare whether or not they use antibiotics or not use antibiotics. This is either systemic and or topical. And of 12, I remember distinctly that there was really relatively no difference in the rate of conjunctivitis. In fact, Ed Wilson called attention to it. He says, is this science or myth that we need to use antibiotics after surgery for strabismus surgery, uncomplicated strabismus surgery? But nevertheless, I know the one prospective study that was started was ended within about 3 or 4 days because there were 8 purulent and conjunctivitis in that series, and so I don't think there were any other prospective studies. But I think most strabismologists use post-op antibiotics. So, in summary, I like to say that infection following strabismus surgery cannot be entirely prevented, but we can minimize the bacterial load, and we can avoid penetration. If you have any question, I think it's obligated to look at that child with a dilated pupil and indirect ophthalmoscope. So did you know for sure whether or not that child has a penetration? In fact, some people, like myself, on recessions, I'll routinely dilate them as I put them under anesthesia in the morning of the surgery, and I look with the indirect at the end of the case. And we must, and this is the most important, we must educate our parents, stay in touch with them, with cell phones, with whatever you want to do, but you tell them, I need to know how your child looks at the end of this week or the next exam, because the next exam may not be for 2 to 3 weeks or maybe even 6 weeks after the surgery if they're from out of town. So you've got to maintain communication with the parents, and I think that's also a very helpful thing to do if you want to pick up any kind of infection early.